Good morning. I'd like to round out this session by talking about the utility of exercise testing for arrhythmia evaluation. And, the realities of this business are pretty clear. One is that ECG measurements are a lot cleaner on a bicycle. In general, EP docs prefer treadmills. It gives you a higher peak heart rate, a higher peak blood pressure. It probably gives you more arrhythmias, but we all know that everybody has more noise on the treadmill. And whatever you're seeing at peak exercise, there's an awful lot of uncertainty that you're going to see. And we need to recognize that not all symptoms are arrhythmia. And so there are going to be times when getting VO2 max and a more quantitative approach to exercise performance is useful. And it would be negligent to not note that I'm spoiled. I get to manage 3 labs and have an option between treadmill and exercise and expired gas analysis. When I was working on a chapter, I talked to the pediatric cardiologist in Ghana who has no exercise testing equipment, and a friend in Colombia who gets to share a bicycle with pulmonary once in a while. So everyone has different resources, and you need to recognize what those are as you're making a choice about what you can do. But then you can ask the question of who can you exercise? And we put together some data. Our fellow Oliver Berry is at Columbia now. That's quite concordant with other large studies. And the short answer is almost everybody. What we found over 5,300 tests, over 1,000 of those had severe heart disease using standard criteria. A third, in keeping with the Boston Children's practice, were adults over the age of 21, and a little more than half had expired gas analysis. A little under half had bicycle modalities, the rest obviously with treadmill. And we predefined a set of high-risk criteria, which you can see here. And that ended up covering about 10% of these patients. These were patients that needed direct supervision, either a cardiology attending or a cardiology fellow in the room at the time that they did it. These included ICDs, which needed to be paired, cardiomyopathies, severe ventricular dysfunction, who were tolerant to let moderate and mild dysfunction exercise with indirect supervision. Indirect supervision turns out to be the echo lab. They don't always know that they're doing it. Clear exertional VT, substantial coronary disease, high risk congenital heart disease with other features, severe aortic stenosis, things like that. Mid-exertional syncope, getting a first-time study. And we listed pulmonary hypertension on that. We don't do exercise testing. Often on pulmonary hypertension, we send them for 6-minute walk tests. About 2% of the patients had 2 criteria, and that left us with 90% of these subjects able to be managed with indirect supervision. Now you're going to get something, and about half the time you get nothing, but half the time you get a little bit of something when you exercise patients. But it turns out most of that's pretty mild, as you can see on these bar graphs in green. And what we found was that 20 of the patients had sustained SVT, all of which was able to be managed expectantly, and 4 of the patients had sustained VT and were more problematic. Overall, 3 patients had cardiac arrests. All of these occurred in high-risk patients. All of them occurred with providers in the room, and all of them had direct changes in their management because of the findings on the exercise tests. There were no deaths, and all of these also took place at our Longwood campus with the whole hospital available as additional support if we needed to. Notably, 2 of these patients were had hypertrophic cardiomyopathy. All had been previously identified as being at high risk and had ICDs. And one, an 11-year-old with severe hypertrophic cardiomyopathy and restrictive physiology, required ECMO for rescue. So when do you do an exercise test, and when might that add value to a arrhythmia evaluation? Well, one is when you're characterizing AV block with or without pacemakers. One is when evaluating patients with long QT, classifying ventricular arrhythmias of really all sorts, but particularly CPVT and similar inherited disorders. And then in WPW, which we've talked about at some length. And I'll touch on advantages that you can get when you use VO2. So here's a pretty typical exercise test with 3rd-degree block and no pacemaker. You have a nice junctional escape mechanism, obvious 3rd-degree block, and an asymptomatic team. And with exercise, they get their atrial rate up to about 170. They have an occasional premature beat, and they get their junctional mechanism up to 110 or so. No symptoms, and a piece of data that if you're trying to defer a pacemaker, you might well use to help defer permanent pacing for that patient. Now, variable block sometimes can be trickier to sort out. Here, you might have 2-to-1 block, but, you might not. And this particular tracing, it's pretty clear that you're dissociated. With exercise, the heart rate doesn't go up a lot. You're relatively convinced that this is 2-to-1 block, but not enough data to really be confident on it. And then in recovery, that ratio stays really the same, making that a more convincing diagnosis. But I'd be fair to say that if you challenged me on that, I couldn't prove it beyond a reasonable doubt. Contrast that to when the rhythm gets irregular and meets pretty classic criteria for 2nd-degree block, when you see group beating and you can quite easily show that you have Wenckebach at a heart rate that's not very fast. There's clearly conduction system disease, even though it's a narrow QRS. Pacemakers obviously have upper rate behavior that can be quite similar. Here you can see upper rate behavior with a pacemaker. And remember, it's not just what the upper rate limit is, it's what the post-ventricular atrial refractory period is, it's what your set-state AV interval, and it's what dynamic correction factors you have. All sorts of things can happen when you get the upper rate slowing. You can get regular rhythm in there, a native beat or a premature beat that resets the timing cycles. So this can look much more confusing than this. And often looking out at the overall rate trend gives you more information than when you try to zoom in on the specific tracing in front of you. Now, long QT is a common referral reason, and you have to ask yourself, why are you getting it? Are you getting it to phenotypically characterize a well-defined genotype in a family that you're doing cascade screening on? Are you doing it to assess ongoing therapy? Are you doing it to ask if there's a potential phenotype in a borderline or somewhat ambiguous situation, which for many of us is one of the dominant reasons that we'll get this. I report a best estimate of a single measure and single heart rate to calculate the QTC through our clinical arrhythmia group generally averages 3 beats with 3 different RR intervals and 3 different QT intervals, which will give you a slightly lower number as it averages those. So here's just a nice example of where it can really enlighten you. Here's a patient with a very normal resting electrocardiogram. You can see the numbers there, who has a KCNQ1 mutation, but in recovery, using the tangent method, which they just went over quite nicely with Dr. Bloom's talk, you can see how the QT lengthens to 495 at 2 minutes in recovery, displaying the phenotype that is expected with that. Now, not all genes are long QT1 and long QT2. Here's a patient who has long QT3 with a well-defined SCN5A mutation, and at rest, the QT is quite long, at least 500. But in immediate recovery, as expected with this particular gene, the QT is shortened so that the only time the child's QT is normal is at peak exercise. I'm speaking a bit to whether or not you would restrict this young man. Everything requires you putting in a clinical context. You know, we thought for a little while that we could just have the children lie down and stand up, but Dr. Dion showed when she was up in Quebec that for kids, that didn't really help very much. And Dr. Davis, in his very systematic fashion, had 100 normal kids exercise and came up with a reasonable bar of what's normal in this data that he and Dr. Berger published now more than a decade ago. And what this generally works out to be is you have to have a QTC greater than 480 in recovery. And you can plot it out like this and see what the recovery curve is, and then put it in context. These are not one-point maneuvers. These are multiple measurements over the course of time. We try to keep them standing for 10 minutes, but not always able to do that because they can definitely be young people with low blood pressure with or without the beta blocker. As we saw at the beginning with ventricular ectopy, it's important not too much to sweat the small stuff. Spirometry in particular seems to be a mess. But you know the history before you test, or should, and prior probabilities are going to help you interpret this and be calm. Stopping and rest fixed almost everything that we saw with this. And again, the challenges occurred in patients that we knew were a challenge. So look at all the data that you get, look at the overall morphology patterns, the timing of when they get their arrhythmias, and the presence and absence. So this is a pretty standard referral. Left bundle branch block, inferior axis, outflow tract origin, ectopy. As they exercise, you get progressive fusion and near elimination of it. But as you keep going, then all of a sudden you have sustained arrhythmia with a essentially identical pattern that then progressed to being sustained, stopped soon after the exercise stopped. In the cath lab, that was not able to be reproduced. And instead, we had isolated VPBs up from the outflow tract with a possibly effective ablation of it. Contrast that to this pattern where a gentleman had a very effective WPW ablation, but continued with the sorts of palpitations he was bothered by, and had this sort of somewhat polyform pattern of ventricular tachycardia induced with exercise that appropriately triggered stopping the study, where things looked a little bit nastier immediately after stopping, and then rapidly returned to sinus tachycardia before it ended. Lastly, of course, is the frightening story with a completely normal EKG, maybe a little bit slower than you'd expect for a toddler. And when exercised, you get a mix of high amplitude noise and pretty obvious complex polymorphic VT. It's hard to decide exactly how many beats in a row you get before the capture beats get in there. And genetic evaluation showed a ryanidine mutation that had been previously judged by Blueprint as being likely pathogenic. In recovery, we have nice examples of bidirectional ectopy going along with the diagnosis of CPVT. For most patients, standard exercise testing will uncover the diagnosis and can similarly be used to test for efficacy of drug therapy or after sympathectomy. If, however, you have either a frightening story with a normal or nearly normal looking exercise test, or you have a gene you identified with family screening, a burst protocol can offer you a way of uncovering arrhythmia that did not exist in a standard protocol. This requires a organized, skilled technologist helping you, and requires a pretty organized and skilled patient and some confidence on your part about what you're getting into. Essentially, you have the patient straddle the treadmill, move it up to the peak work load and peak speed, and then jump on the treadmill and exercise for at least a minute, if not 2 minutes, before you put it back into recovery mode. Though for patients with uncertain genes and uncertain phenotypes, this can be an important addition to the toolbox. So the summary for this is that benign ectopy is certainly capable of sustained VT during exercise testing, though usually is not dangerous and will stop. CPVT usually gives complex ectopy, gives it at a relatively early time frame, heart rates at 120s to 30s. And if you have apparently effective therapy or a latent gene that you're concerned about, then burst protocol can enhance the sensitivity of the exercise test for CPVT. And lastly, complex ectopy in recovery suggests a more arrhythmogenic cardiomyopathy process and requires more concern. WPW has been a staple of the exercise lab for many years. It's really important to once again recall the parts of the physiology and hence of risk assessment. Exercise testing looks some at antegrade conduction characteristics. What we're obviously concerned about in WPW is those characteristics at rest and those characteristics with catecholamines. They can be quite different. And exercise testing may offer at least some insight into that. The alternatives data that we're looking for, of course, are retrograde conduction, which you can classify as yes, no, or mostly, but you can't say anything about that in the exercise lab. And anatomic location, left septal and right, which you knew as much as you were going to know at the beginning of the exercise test. And you have to remember that there's some mimics where you might not quite know what you're looking at until you get more data. So right lateral pathways are obvious. And if they go away, they're obvious. They're not a real challenge for this. But left lateral pathways can clearly be more of a problem. They can be more difficult to recognize. and much more difficult to know whether it's gone. So in this case is the development of this sharp little Q wave here, the pathway going away. Probably, particularly if that's what we want to see. But there's pretty clearly delta wave the rest of the time at a heart rate of 120. Asking ourselves the same question again here. Is this really intermittent? Again, probably is the answer to the question. And, this was a right posterior septal and rate only pathway. At baseline, the SPRI was greater than 400. On isoproterenol, it was 280. I appreciate that those numbers are discordant and a bit decided by me, but it also represents the challenge of interpreting this data. And if we had any take-home message from Dr. Etheridge's wonderful talk the other day, it's that there are no good tests for what antegrade conduction is going to be with clinical atrial fibrillation. That simply is not a piece of data we get to acquire, even in the cath lab. And exercise testing is similar to that. And then I'd say the last question is, really deciding whether it's gone. And that is much harder with left lateral pathways. Keen and I tried to score these a number of years ago. We disagreed a third of the time. And I think we frequently find ourselves disagreeing on those findings. And you have to ask the question when it's this subtle a pre-excitation as to whether or not it even is pre-excitation, and particularly whether it's WPW or it's a fascicular ventricular pathway or a similar physiology in which the data needs more information to decide that you're not at any sort of risk in that. So what conclusions can we make? I think it's fair to say that the exercise ERP predictions are imperfect. They're imperfect, just as they're imperfect from looking at intermittent WPW, just as they're imperfect from looking at APRP cath lab. None of them 100% of the time predict the presence of rapidly conducting AFib. There's really no exercise data whatsoever regarding retrograde conduction, so you don't know whether the patient's going to have SVT. If they get SVT in the exercise lab, it's an accident. Left-sided pathways and things like fascicular ventricular pathways can be very subtle, and you can be disagreeing with yourself. So all the data needs to be put in the context of symptoms, age, perspectives of risk, and the perspectives of the risk of an ablation. So VO2 max can probably help in difficult settings. Particularly in congenital heart disease, there's compelling data that decreased VO2 max is associated with increased mortality and tetralogy and other forms of impaired congenital heart disease. The threshold for when that risk really increases may be ridiculously low and as low as 15 cc's per kilo per minute. So that subtle interpretation of that is an important part of looking for people and can really add value in deciding how much of a war you're going to spend looking at the arrhythmia. And not all exertional syncope is arrhythmia. Here are two patterns that we see relatively regularly in exertional syncope. The stories often clarify things for you, but in the top tracing, we have a patient who exercises hard, gets their heart rate up, their blood pressure doesn't do a thing until recovery, when we have to lie them down, and then their blood pressure goes up really only to 120, but at least better than the 90s and win throughout exercise. And contrast that to this youngster who has a really excellent exercise performance, 64 cc's per kilo per minute. They tried quite hard, an RER of 1.12. They exercise for 8 minutes after reaching their aerobic threshold, and near peak exercise, their blood pressure collapses, not because they have an arrhythmia, because they've completely mismanaged their exercise performance and need to understand how to pace themselves a little bit. So what sort of semi-conclusions can I offer? I think one is that exercise testing can be safely done in an enormously wide range of pediatric and adult congenital patients. But recall, doing them safely in this number of patients is not doing them safely in everybody. We actively excluded the highest risk patients, particularly including those with pulmonary hypertension. But with this, you need direct supervision for really only patients. Exercise testing is a relatively specific physiologic probe, but it has at best mixed precision. And I always think of it as part of characterizing the patient, not rarely as the diagnosis. And for some patients, particularly congenital heart disease and non-arrhythmic syncope, VO2 max can further inform some cases. Thank you for your attention.